in disease prevention. So welcome everyone to this session, and we again hope that you really enjoy it. There will be some feedback that we will be requesting at the end of the session, and we would really appreciate that feedback because it's going to guide what we do with this session in 2025. So we want feedback on today's session, but also what you would like next year as well. If this is a valuable resource and engagement and you want that to continue in 2025. So please do that at the end of the session. But first and foremost, today's session is run by the two Davids from the public health team. We've got David Farrell, who sits in Broken Hill, who is our Senior Environmental Health Officer, and he's going to be giving us an update on the Housing for Health program. But to kick things off, David Orozco, who's our public health nurse in our Dubbo team, will be presenting on skin health and what can go right and what can go wrong. So, and of course, Kathy Hale's online, who will be just sitting quietly, I think, but of course she will be there for support as we continue. So, but before we kick off, there's just a few housekeeping rules. So everyone on mute. We would appreciate if everyone can put their first and last name, the role and the place of where you work in the chat. And that way you can also receive a certificate of attendance. Please use the chat to ask any questions, and I'll be monitoring the chat so we can, bring that up. But if you do want to ask a question, please unmute to have a yarn with our presenters. The first part of the session of the education is recorded, but the yarning session at the end is not recorded, and we're hoping that that will really improve engagement from everybody so we can have a really safe and happy chat. Slides will be shared at the cessation of the session, so you've got all the resources moving forward for your yarning sessions with your community members. And yeah, once again, just please complete the evaluation before you leave the meeting. So Erica, I think, is that the nuts and bolts of all the housekeeping? So I'm going to hand over to Wendy now for an acknowledgement of country.
I'd like to acknowledge the country. I'd like to acknowledge the land, traditional custodians of the land we're meeting on, and remind people that we live and work on Aboriginal land. Also acknowledge the Aboriginal elders of the community, those who have passed, and all Aboriginal people attending this meeting today.
Thanks, Wendy. Okay, so over to David to start our education session on healthy skin. So thanks, David.
Hi everyone, David here, David Orozco, so one of the two. But yeah, so there was some feedback, I think, from last session where people wanted about health skin, and we talk about and so we're going to talk about that today. The work that we do within the public health is to do with communicable diseases and notifiable diseases. So there's a little bit of a tack on that as well, a little bit of a take from that end. And yeah, I'm going to take myself off the camera, and I'll just keep talking, but I'll put myself back on when we're doing the yarning. Yeah, so today we're going to talk about healthy skin. So next one, please. So the learning outcomes for today, we're going to aim to understand a bit of basics about what can go wrong with skin health. Now, this is not an exhaustive list. There are quite a lot of other things that can go wrong with the skin health, but we're going to look at it from the point of view of a couple of infections that are afflicting, particularly in Australia, particularly the less fortunate, I think you could say, or the some vulnerable communities, especially not exclusively. So that they can appear anywhere. But as with a lot of bad health outcomes, they tend to afflict more the people that are already worse off. Now, so we're going to talk about a couple of bacterial infections and scabies. Next, please. So then the second thing that we're going to talk about, another learn outcome, is what can really go wrong. So really this is complications from bacterial infections on skin and complications from scabies. So we'll talk about crusted scabies a little bit. We'll talk about acute rheumatic fever and rheumatic heart disease. We're going to talk a little bit about invasive group A strep, which is connected to the previous bacteria, and then post-streptococcal glomerulonephritis, which is also connected to group A strep, common with bacterial infections on skin. Next, please. The last learning outcome, we're going to talk about the things that can go really right. So we can talk about all the ugly stuff, and then we can talk about sort of the light at the end of the tunnel, the things that can go good. Next, please. So it's good to touch a little bit on skin. Again, this is not an exhaustive list. There's a lot of other things that the skin does, but we're going to talk about just a few that are relevant to this. And if anyone has any questions, we can discuss it a bit further. So the first thing that the skin does, it keeps things in. So the skin is like a bit of a big covering all around our body. There's lots of stuff in there, organs, blood, water. There's lots of like fluids and stuff going in there, and the skin keeps it all in. Obviously, it's not just the skin. There is other layers and stuff, but you know, at large, the skin plays a big role. One of the things that can go, one of the things that are really worrying with when the skin is not intact, like for example with big burns, is people lose a lot of water, and that's not good because people get dehydrated really quickly when the skin is not keeping everything in. A second thing, keep things out. So just it is stopping from things going out. It's stopping from things going in. So when you think about all our surroundings, where we're going around, we brush against a wall, we sit down somewhere, you know, we go swimming. The skin is constantly protecting us from things entering that shouldn't be in there. So it's our first line of protection. The body's got a pretty amazing way of keeping us safe, keeping us from getting sick, and there's different levels to that. And the first one is the skin. So yeah, it keeps us from getting sick. It's our first point of protection. Next, please. Keeps things cool. So another good function of the skin. It helps us to regulate temperature. So sweating and moving blood around to keep it cool. The skin is involved in all that. So this is a complex organ. Next, please. And it keeps it real. So the skin helps us to navigate this world that we live in. It's a massive sensory organ. So we've got all sorts of different nerves. You know, it helps us to feel temperature, which is protective to us, helps us to feel pain. It helps us to feel sensation, so we know what's going on. So there's all these different types of sensors, nerves connected in there. Now, again, this is not an exhaustive list. The skin is very complex. It's got so much to it, but I just wanted to touch a little bit on, you know, just how good it is and why it's good to keep it healthy. And yeah, thank you. The next one. So the thing that we're going to focus on today is keeps things out. Yeah, thank you. So keeping things out, just next one, please. Everyone can just have a look at that one. So it's a physical barrier, you know, like someone famously said, we're going to build a wall. And that's basically what the skin does. It is a wall around us. Next, please. It's waterproof. Again, I was talking about things can't get in. So it is permeable to some things. So we do absorb some things via skin, but at large, it is keeping a lot of things out. Next, please. One of the big things that the skin does is keeps microorganisms out. So things like bacteria. You know, there are places in the body where bacteria is welcome and it's got a function and it's got and the body can tolerate it. But in most of some places yes, some places not, and the skin keeps it out. Yeah. Next, please. Another thing, you know, protection from radiation, UV. We are always, you know, getting sun exposure, and some people more than others have more melanin. You know, that helps us to block out UV. Some people get sunburnt. The people that have got more melanin usually don't get quite as sunburnt. So that's another thing that the skin does, you know. But everyone's got some sort of UV protection, just at different levels, and it just suited to where you live, I guess, originally a long time ago. Next, please. Also, protection from trauma skin. Imagine if we were walking around with no layer of skin. So the outer layer of the skin is composed of quite a lot of dead cells. And so it's got that leathery protection on the outside. So things come by and brush you. You know, that's why not everything hurts. Like the outer layer of the skin doesn't hurt. There's a lot of leathery dead skin cells there, and that's normal. That's how it works. And so it's giving us protection from all different kinds of angles and things. So thank you. Next. So what can go wrong? Again, this is not an exhaustive list. We're going to talk about a couple of things. One of the things that was requested was school sores or impetigo. And so we thought we'd talk about these. Now, has anyone ever seen something like this? You don't have to answer, probably yes. So you get these sort of golden crusty bits on the skin. So bacterial infections on the skin, impetigo, most of the time caused by these two bacteria, group A Streptococcus and Staphylococcus aureus. So people have heard of staph infection or strep infection. So strep, often strep throat people talk about. Same kind of bacteria with the Streptococcus. And they're usually the culprits in school sores. Next, please. You can have two different types. So you can have skin that was normally healthy. You get the bacteria infecting, reproducing too many numbers, and then they start giving you problem. That's when you get a primary infection. Okay, that's produced by bacteria populating the skin, but it wasn't there before. Thank you. And then you can have a secondary infection. And this happens when there's already some damage to the skin, and then you get bacteria that comes in and then starts infecting. So, for example, someone gets an insect bite, a mozzie bite, scratches it, it gets a bit open, get a bit of bleeding happening, and then bacteria, gets a bit dirty. Bacteria comes in there and starts reproducing. It likes that moist, that wet, warm environment that the body has, loves it, thrives in it, reproduces, and then you get a secondary infection, which means that skin was already damaged, it already had a problem, and then you get something else. And this can happen with other things, like scratches, eczema, scabies as well, all these kind of things. Thank you. Next. So it's important to differentiate, so tell apart from other conditions, because like I said before, there's a lot of other things that can go wrong with the skin. And you have things like dermatitis, which is, inflammation of the skin caused by something else. Could be an irritant, could be someone is using a different soap, someone is quite sensitive to something that irritates the skin. And so it might not be a bacterial infection, it might just be the body's reaction. You got fungal infections, they look different and they're treated different. And so we have to make sure that we differentiate. Varicella, you can get viruses that give you rashes and all that kind of thing. So it's important to know when you're getting impetigo or a bacterial infection and when it's something different, because you will respond to it quite differently. Okay, next. So for impetigo, the treatment can be oral, so via tablets, or topical via cream. It is recommended that after 24 hours of having treatment, then kids, or sometimes you get it as an adult, but normally kids, they can go back to school 24 hours, so a whole day after having treatment, they can go back. They're very infectious, so quite, especially little kids, they dirty little things, they touch and they play together and they go and they say no when you ask them to wash their hands. And so it can be pretty tricky, to keep kids from passing it on. So you just have to be really careful, and especially when before people get treatment, before little kids get treatment. Thank you. Next. Also very important to keep lesions covered. So if there's a wound, sometimes these infections when there's not an opening in the skin. Sometimes the skin happens as a result of the infection, and so it's important to keep it covered because they can be infectious, but also because there can be complications. So important to keep them covered and to keep them clean. Thank you. Now, risk factors. We've got some low socioeconomic people, so people that are not doing as well in general in life, as in employment, housing, all this kind of thing, education. As with a lot of other health conditions and a lot of other things, it tends to be worse in disadvantaged people. Overcrowding in living spaces as well, and poor hygiene. So these are the things that are going to be risk factors. Now, it's important to note that they don't only affect people in low socioeconomic demographic. Like, you can get it anywhere. So no matter where you live, where you eat, where you go to school, anyone can have it. But we do see more concentration and it happening more when people are already in a disadvantaged position. Next. And then we'll talk about scabies. So they're little mites. So I guess they could be categorized as a the word just fled me a bit. So they're super itchy. They're little microscopic mites, so you can't see them with the naked eye. Sometimes you can see on the skin where they have done their little burrows, but you can't really see them on skin. So sometimes it can be a little bit hard to tell for sure. Parasite is the word that I was thinking of. The parasites, I guess, because they're living in your body. Freeloaders. Yep. So next, please. So these little parasites, the little mites, they'll mate, and then they'll start digging a tunnel inside the skin. And when they're advancing under the skin, they lay eggs, and it's so itchy and it's so bad. And even talking about it makes you feel itchy sometimes. So transmission is skin-to-skin contact. So you have to be touching someone, and it's prolonged skin-to-skin contact, which means that if you brush into someone as you pass by, you're very likely to get it. If you high-five someone, probably not going to get it from that. And there's something that people call fomites, which is if I pick up a phone and then pass it to someone else and I've touched it, are you going to get scabies because you touched my phone? And it's very, very uncommon. So not normally through objects. It doesn't travel that way. You have to have close contact. Thank you. Normally you find the itching, which is how you normally are aware that something's wrong, in the webs of fingers. So in between your fingers, sort of in that fold. Other skin folds as well. So elbows, wrists, back of the knee, around the areola, which is sort of at the outside of the nipple, sort of in that area. Genitals as well. You know, they've got a lot of soft skin and a lot of folds in there. Yep, unfortunately, scabies love that, and they'll go crazy there. So next one. They need people to live, so they'll die within 24 to 36 hours of being off a host. Again, meaning if you're sitting on a bench, that kind of thing, like it's not likely that you'll get it. You need that close contact. They'll just dry and die off pretty quickly. Next, please. Diagnosis is clinical, so often you're sure that it's scabies because you can see the lesions, so you can see the little tunnels that are burrowed. You see the patterns where they are, because other things can give you itchiness in those areas of the skin. There's another way of looking at it as well by doing skin scraping. So you can't really see them when you scrape bits of skin into a little pot, and then they send it to the lab. They look at it under the microscope, and sometimes they can find some mites. Sometimes they can find some poo. They can see that that's mite feces. Sometimes they see the eggs, and then that can be confirmed. However, you don't have to be confirmed by a lab to be able to get treatment. The clinical diagnosis might be enough. Thank you. So treatment can be oral or topical as well. It's treated with ivermectin orally, or with Lyclear, permethrin cream. And it's done 7 days apart from the first treatment day 0, second treatment day 7, and that is because there's a life cycle of the little mites. So the eggs that are there don't get killed with the treatment, and then they'll hatch, they'll come out, and so you treat second time round, and then you get a whole generation of mites killed off. It's enough time for you not to get for them to just keep mating and having eggs, and then just continue the cycle. Now, it's important as well to treat everyone in the house, because it's assumed that people within the house are going to have close physical contact. It's likely that more than one person will have mites on them, so you want to treat everyone. And another way that you can clean up as well is by cleaning the linen, cleaning clothes and everything. Like I said before, they don't survive that long, especially in dry heat, so high temperatures and dry environments. So if you get all your clothing inside rubbish bags, leave them out for a day or two, then those mites will die if they were there. So it's really important when you treat someone, you treat everyone to make sure that you get rid of it. Otherwise, it just keeps bouncing back and forth, and you do this never-ending story. Next, please. So again, one of the risk factors, again, low socioeconomic disadvantage, disadvantaged people at higher risk, but it can happen to anyone, anywhere, as long as you come in contact with the mites. High incidence in institutions, so things like aged care, things like prisons or boarding schools, that kind of thing, where you get a lot of people living in closeness, more likely because of that higher contact. But living conditions are a big factor. Next one, please. Okay, so now that we go into the things that can go quite wrong, the thing that how it can take a downturn. Next, please. Again, this is not an exhaustive list. Sorry about the picture. It's a little bit graphic, but that's what a bad case of crusted scabies looks like. Usually, you won't see it like that if it's just a simple skin infection of scabies. Normally, the body's immune system will fight it back and keep it at bay. Normally, you would only see this if someone was immunocompromised. So someone has diabetes and their immunity is not working properly. Someone's on dialysis, so the kidneys are not working properly, and they're on this ongoing treatment. Someone's on cancer drugs, and they really the immune system is really shot. Another example would be, say, someone that had HIV, that the immunity was really low because of so immunity not working well, mites just thrive and keep reproducing and reproducing. Next, please. So very, very, very infectious. When we said about a simple infection of scabies, not quite as infectious, you need significant skin-to-skin contact. With crusted scabies, the skin keeps thickening and creating this crust, hence the name crusted. That you start getting some fissures on the skin starts cracking because it's so damaged, but you get this thick layer of skin, and it's basically just a lot of skin flakes on top of each other, crusted. Mites are living in these crusted scabies in the skin, and the skin flakes will fall off, and mites can survive for longer in these in these flakes. Now, this is very uncommon. You don't see it as much unless someone is quite compromised. In these cases, the fomite, again, the object transmission is a lot more common because the mites will survive in these bits of skin for longer. So if you had someone in a household that had crusted scabies and then the skin flakes are falling on the ground, and you have a baby crawling through and picking up the skin flakes, you will get transmission that way. So it's a lot more infectious. Apologies for the graphic pictures. So like I was saying before, next one, please. It requires longer treatment, sometimes until it fully resolves, which might be quite a few cycles, not just the 7 days apart. And it may require other drugs as well. And there's other mixtures that they do, like with tea tree oil and things lactic acid, and a few different mixtures that the pharmacist will do, and then as well as other forms of treatment, like the oral ivermectin. Next one. So it damages the skin quite badly. It creates ports of entry for bacteria. And one of the things that can go wrong with scabies is not necessarily just the scabies, but that it creates an entering portal for bacteria to come in and infect those places in the body that cannot deal with bacteria. Thank you. Like I was saying before, it's not as common. Thank you. And a big thing about this is because it looks so bad, because it's such a bad condition. It does bring a lot of shame on people. So people get really embarrassed when they have. I mean, even if it's not a crested scabies, I think scabies and other conditions tend to bring shame to people because they feel like there's something wrong with them because they've got this. And so often you'll see people covering up. So they'll have, even if it's hot in the middle of the day, you'll see people with lots of jumpers and lots of covering. And that's because there's a lot of stigma that comes with having infections on the skin. So that's something to be mindful of. Okay, so we talked about the couple of different bacteria that was causing school sores or impetigo. We talked about group A streptococcus. One of the things that group A streptococcus, one of the complications is acute rheumatic fever. And I'll explain what this means. So when you get exposure to this group A strep, which can be from skin infections as a port of entry, it could be from strep throat, like I was mentioning before. The bacteria can get into the body, and when you have repeated infections, then the body starts mounting this out of proportion inflammatory response as part of an immune response. So your body, trying to defend itself, kind of freaks out and creates too much inflammation. So it's an autoimmune condition, really, and normally repeated group A strep. So I think most of us would have probably been exposed. I think probably every one of us would be exposed to group A at some point. Normally, if you've got a strep throat, you'll get antibiotics. If you get school sores, you get antibiotics, and then you won't come in contact with it for a while. But when people are living in close like overcrowding spaces, very close to each other, and they keep getting infected repeatedly, that's when you get this response from the body. Next, please. Yeah, so pharyngitis and impetigo, skin and throat infections, most common in ages 5 to 14 for the same reasons that I was saying before. Kids are just so much more exposed to infection, and you get it a lot in these years. So it's really uncommon to see acute rheumatic fever. I'll explain more what it is a bit later, but it's really common to see it in ages between 5 and 14. I'm assuming before 4, there's not enough time for enough infections to be able to, I guess, cumulatively provoke this response. And so you start seeing it. There are some cases where you see it, and I've seen it. I think even down to 3, which is quite rare, but you end up, you can get it. But normally 5 to 14 is the highest risk. You still see it later on. 20s, even rarely up until 40s, but as people get older, rheumatic fever is not quite as common. It tends to drop off after that, but you get a big peak 5 to 14. Next, please. So this is a condition that affects the joints. So big joints like elbows, wrists, knees, very commonly. Sometimes ankles, but very commonly knees and elbows are common. You can have pain on joints on one. You can have it migratory, so maybe there's a joint that hurts, and then a few days later that sort of goes away, and then there's another joint that starts hurting. It affects the brain as well. Sometimes you see it, not as often, but sometimes you see something they call Sydenham's chorea, chorea for short. And people start getting jerky movements, like non-rhythmic. So it doesn't necessarily look as rhythmic, not as regular. And it's also it goes away when people go to sleep, and that's because the brain gets some sort of inflammation. It's not very well understood. They think it's because there's some inflammation around the brain, and so the movements get affected that way. Skin, not as often, but sometimes there's some subcutaneous nodules, they say, and sometimes a rash. Uncommon. I've never seen it, but it is a thing. And heart, which is the thing that we're not. That probably one of the worst outcomes is probably when the heart gets affected, and we'll talk about that a little bit later. Thank you. Something it's quite responsive to NSAIDs, so non-steroid anti-inflammatories, and that is things like aspirin, things like Nurofen. There's a whole range of them, but normally quite responsive to NSAID. So usually they try to not give it if someone's suspecting that they've got that there's someone that has got rheumatic fever, they'll hold back on the NSAIDs until they get to hospital. So they try to use something like Panadol or different types of analgesia, because you want to keep the symptoms, I guess, alive until they get to hospital, they get assessed, and then they'll give Nurofen to check to see if it works. And if it works, then it's supporting evidence to say that it probably is rheumatic fever. But it is a difficult diagnosis. There's no specific biomarkers. A few years ago, there was a big study being done to see if they could find any particular test that they could do with blood that could say positive for rheumatic fever, but there hasn't been anything. So it's a bit like a point system, and they've got what they call manifestations. So if you score enough points for major manifestations and enough points for minor manifestations, then they can say, we think you've got rheumatic fever. We've ruled everything else out, and we think it is rheumatic fever, and then that's how it gets diagnosed. Unfortunately, it's not super straightforward. And sometimes kids will say, they fell off a tree, or they were playing soccer, and then a couple of days later, or that afternoon, or something else, like close by, they started feeling pain on the knee, and then the pain went to the elbow. So sometimes it can be written off as trauma, as in someone just got hurt, and that can be a bit tricky, because it is hard sometimes to tell, and it just takes a clinical decision at the end of the day when a doctor has to say that's what they've got. Next. So treatment for this is not as clear cut. Normally the inflammation sort of subsides with a bit of time, and the ongoing treatment is prevention, what they call secondary prophylaxis. So these are penicillin injections, long-acting penicillin injections that go into the muscle. They get given every 28 days, and they're quite painful, which makes adherence hard. People won't come back for them because they hurt. And so for the people giving them, I'm not sure if AHPs do injections in New South Wales. I know some other states do. I think we're looking into that maybe. So that's some of the things that the person giving that's one of the things that the person giving the injection has to be quite mindful of. It they hurt, and so you have to really build rapport to make sure that kids keep coming back. And often we see in kids that are high school, sort of the rate of adherence to these prophylaxis will drop off, and then we get more episodes of rheumatic fever, which can then lead to complications. Usually when they start getting into the teenage years and they start becoming a little bit more independent, we get a big spike in that age group often. Okay, so the sad thing about rheumatic fever is that virtually it's non-existent where there's good living conditions. Once upon a time, it used to be quite a common thing. Kevin Rudd famously has got rheumatic fever when he was a young guy. He got it, and then later on got rheumatic heart disease and went on to have the treatment for it, which I'm going to talk about a bit later. But it used to be a lot more common. It's not anymore as common, except where there's not good living conditions. Thank you. Highest documented incidence in Australia. Aboriginal and Torres Strait population highly represented, sadly. I think there might be, like, we're probably very good at documenting in Australia conditions, I dare say, working in public health. But in overseas, there might be other places where it might be high and it might not be as well documented, is my guess. This is not official, but I'm thinking part of the reason why we've got a high documentation of them in Australia is because we do document them in other countries where there's bad living conditions. They don't get as documented. The sad thing is that we do have, I guess, a lot of people in Australia with living conditions that have improved, and we still have some groups that are lagging behind. Yeah. Thank you. Next. So rheumatic heart disease, that's a complication of rheumatic fever. One of the things that we talked about before in the previous slide was that there can be some heart inflammation when you get rheumatic fever. The heart gets inflamed in different parts of the heart, but mainly one of the biggest parts affected and longer term affected is heart valves. Mitral valve and aortic valve are the valves that most commonly get affected, but most of the time the mitral valve is the one that gets inflamed. And there's 4 valves in the heart, and they regulate the flow of blood. So their job is to stop blood from coming back the wrong way. So it's a one-way street. Blood comes in from the body, comes into one chamber to the other. There's a valve in between, then gets shot out to the lungs, comes back from the lungs back into the heart, into another chamber. Then that chamber squeezes it out to the left ventricle, and that is the biggest in terms of muscle mass. It's the biggest one, and it shoots out really hard out to the rest of the body to pump all the blood out. So it's really important. And then it sort of circles around, comes back into the heart. So this flow is really important, and you want it to keep going in one direction, not to come back. Okay. When you get rheumatic fever, you can get inflammation in those valves, and they start changing shape. They start getting damaged, and then you start getting some backflow, and that's not good. Thank you. Next, please. They stop working properly, and they can give you really bad symptoms if you don't get the good flow of the one-directional flow of blood. You start getting pooling of blood in the heart. Sometimes you can get clots. Sometimes you can get swollen legs. You start retaining fluid because the blood's not moving. It's not emptying properly, and so you get pulmonary hypertension. So you can get a lot of pressure in the wrong places of the body, and so the complications can be pretty bad. Next, please. Unfortunately, the symptoms are not really noticeable until the valves are really badly affected. So the things like what I was saying before, heart failure, when people's lungs start getting filled with fluid because the blood is not, the fluid is not getting moved around, and it sort of starts pooling, people start getting short of breath. That's bad. That's not too far from actually needing open heart surgery and having a valve changed. So they can be mild, moderate, and severe is how they categorize rheumatic heart disease, and normally you don't get symptoms until it's a bad kind of moderate or severe, and that's the last step before you get open heart surgery to get valves replaced. Yeah. Next, please. So diagnosis is a lot more certain. So when you do an echocardiogram, so an ultrasound of the heart, they'll have a look at the blood flow, they'll have a look at the structure of the valves, and that's when they know for sure. It's a lot more certain than diagnosing rheumatic fever, but it's bad because that means that there's some permanent damage on the heart. It's sad. Yeah. The long-term treatment for rheumatic heart disease, once it's identified, is trying to prevent that more rheumatic fever episodes occur, and that's through that penicillin injection every month. Next. It is preventable. It is, some people say 100% preventable. I'm not too sure if it is 100% preventable, but it is very preventable. And proof of that is that we don't see it in most of the population in Australia. Next, please. In New South Wales, there's not a lot of incidents. So New South Wales, Northern Territory, Western Australia, and Queensland, there's a lot more of it. Highest incidence of Australia in the Northern Territory. in New South Wales, there's not as much, which means that we're not looking out for it, which means that when we do get a case here and there, it's usually quite advanced. And so we're not catching it early on. So that's something important to keep in mind when we go out and work and see people, just to keep in mind that could it be rheumatic fever? You know, something to think about and put forward if we think there's a case for that. Next, thanks. So I'm conscious of the time. I'm perhaps taking a little bit too long. I'll try to speed a little bit, but I'll just touch on these two. Group A strep, same bacteria, invasive disease. So like I was talking about before, there are some places where bacteria can exist. Mind you, it needs to be the right kind of bacteria. So our mouth is full of bacteria. It's got its own ecosystem happening in there. There's balances. The gut has got gut bacteria, something that's been talked about quite a lot. A lot of bacteria, but not just any bacteria. There's some harmful bacteria, but in general, there's massive amounts of bacteria. Skin's got its natural flora. Other places like vaginas, like there's places where bacteria can live. There are balances and there's a healthy sort of environment of bacteria. Mind you, not every kind of bacteria. There's some that we can't cope with, even in the places that need bacteria. There's other places in the body where they need to be bacteria-free or sterile, and they do not cope with infection. So we call these sterile sites. So things like in our blood, in our organs, in our bones, in our brain, there shouldn't be any bacteria in there. And if there is bacteria coming in there, the body will try to deal with it. Sometimes it can, sometimes it can't. And when it can't, the outcomes are pretty bad. Next things. So breaches in the skin, they can allow bacteria to enter into those sterile sites and cause what we call invasive disease, which means bacteria where it shouldn't be. Thank you. Next. The body can be overwhelmed and become septic. Sepsis is it's a complex thing. I'm going to try to oversimplify it. Some people say it's an infection of the blood. It's not really an infection of the blood. I don't think that's a good explanation. The way that I'm going to try to explain it is it's when there's a bacteria, a pathogen, so bacteria or a foreign organism that causes infection in a place where it shouldn't be. The body then tries to deal with it, gets overwhelmed, and then freaks out and will start failing in doing the normal functioning. So then you start having a medical emergency because the body, the veins and arteries will freak out. They dilate, they become too big, and then there's not enough blood to move around and get to all the organs. And so that's when they say you're having multi-organ failure. It means organs are not getting enough blood. Your blood pressure will drop because there's not enough blood to keep up all the pressure inside your body. And so pretty quickly your body starts to shut down. And doctors and nurses and Aboriginal health practitioners have to act quickly because if you don't, people can have permanent damage and die. So sepsis is very serious. We have to act quickly, and one of the things that we need to do the quickest is to get antibiotics in. Next, please. So treatment is with antibiotics and supportive measures depending on the severity of illness. Like I was saying before, some people end up going to ICU, some people don't need to ICU, but they might need a fluids, so they might have to put a drip in and give fluid to be able to keep up the blood pressure. Otherwise, people will deteriorate and go downhill, like I was saying before. So yeah, you need to treat it quickly. So when we talk about invasive disease, this of Group A strep, this is the same bacteria that we talked about with the skin infection, gets in the wrong place, and then it wreaks havoc in our body with potentially fatal consequences. So yeah, another condition that we've got here. Yeah, that's okay. We'll move on to the next one. Another condition that I want to touch on is also caused by Group A strep, and also can be other. You got Group A, and then you got B, C, D. So we've got a bit of a range of different streptococcal organisms. So post-streptococcal glomerulonephritis. This is another autoimmune response to an infection of Group A strep. So it produces an inflammatory response in the kidneys. The body starts attacking itself. Kidneys are meant to clean blood, and so they filter some things, and they get rid of byproduct, and excess salt, excess potassium, and all the things that we need, but have too much of, or the things that we don't need because they're byproducts of our body functioning. The kidneys will filter out and filter in. So they're important to keep things like protein in. So when someone starts peeing and they do a test and there's protein in there, not good. The kidneys are leaking protein. So yeah, it decreases their function when you get this post-streptococcal glomerulonephritis. Kidney function will go down and they're not working properly, which can be also pretty life-threatening. Next things. Normally you get a skin infection or a sore throat from group A strep, and that precedes I'm going to call it APSG N. Yep, next things. Most common in children 5 to 12, and when people get a bit older, over 60. Thank you. Next one. Highest incidence again in Aboriginal and Torres Strait population in Australia, and we also have the highest rates reported in the world. I'm also assuming that it's because we are recording them and other countries might not be. So there might be higher incidence in other places and it just goes not documented, not reported. Thank you. Next. But it still means that we get a lot. Presentation includes fluid retention. So this is a bad case. There's a lot of cases that don't get this bad, but a bad case kidneys are not functioning properly. So there's fluid retention. People start getting puffy faces, swollen legs. They start getting blood in urine. So they start peeing and it comes out like tea color. They do a test and there's protein, but many cases will be mild and asymptomatic. So people will have it and not realize that they're having it. Next, please. Treatment is with antibiotics and again, other supportive measures depending on how sick people are. And yep, next. And incidence decreases when conditions of living improve. So the better living conditions people have, the less that we are going to see this. Next, please. And I'll just race through this one because I know I'm taking quite a while. So how things can go right. Again, this is another disclaimer. There's not it's not exhaustive list, but one thing that we need to remember as a starting point is that prevention is the best way. So the body heals itself. So if you think about, we talked about different things like giving antibiotics. Antibiotics will kill or inhibit bacteria growth, but ultimately they are supporting our immunity to heal itself, to get to a better place. So a lot of the medical interventions and a lot of the things that we do are to help the body to do its job better in keeping us alive, to maintain that balance. And so if we think about, even someone gets surgery, the surgeons are doing a great job, life-saving measures, but then we are counting on the body healing itself and that tissue coming back together and the skin closes itself. And so basically we're just helping the body to heal itself, if that makes sense. And so the things that we can do every day to help the body to be strong, to have a better starting point if something goes wrong is, next one, is eating. So eating gives us energy requirements that we need, but it also provides good nutrition to have those building blocks for the body to repair itself and to be getting all the right fuel that we need. Sleep. So there's a lot to be said for sleep. It's not something that's talked about a lot, but there's a lot of evidence that shows that it is quite connected at recycling our body's energy. It gives us it's connected to our immunity. It's connected to our cardiovascular function, thermoregulatory, so how we control our temperature, metabolic function, reproductive function, respiratory function, and endocrine function. So just to give you an example, people that will have a few really bad night sleeps in a row, they'll test their insulin and they've got higher levels of insulin. People that are having really good sleep. Now, this is not to say that you've had a child, you've had a few bad nights and then your endocrine system is shot. It just means that over a long period of time, it makes a big difference and it helps our immune system. Even emotional, it's a bit of a reset. Every time you have a sleep, it will reset and you wake up and things don't seem as bad as they did the night before. It's because there's sleep it's just, quite connected with all of our body. And so good sleep equals strong body. Next, please. And then play. So physical activity, another one that's, we all know about it, and we say we should do more exercise, and we all know that, but it's good to understand why. So exercise and physical movement, not just, doesn't mean just you clock in an hour at the gym or you go, you do, it's moving around. It's doing things that are going to keep us active. So it stimulates our immune system. It helps us with metabolic health. So, even some things like a vigorous walk for half an hour after dinner will help insulin levels to not spike. So it'll help our metabolic health to stay good, and therefore reduce inflammation, all these other things, but preserves function. So the stronger we are as we age, the better that we don't fall. One of the biggest indicators of health outcomes is grip strength. So how strong your hands are, how tight you can squeeze. And there's a lot of reasons for it. I think some of them are not as clear, but there's other things, reduces oxidative stress. So it'll stimulate your body to regenerate itself, heal itself. When you exercise, you inflicting a bit of damage, and then the body repairs itself stronger, better. Also, the more calories that you're burning, the less fat that you've got around, and the less inflammation. So fat, especially in your tummy area, equals inflammation, equals not as strong, not as good of a start when it comes to fighting off disease. Next, please. Prevention is the best way. So living conditions, overcrowding, a big risk factor for all these things that we've been talking about, gas infections and scabies. Next, please. Hardware, so access to showers means people can wash their hands, have showers and all that. If we've got overcrowding, these facilities will break, hardware is not going to be any good, and people are not going to be washing. Okay, next, please. Education, so hygiene practices, even if someone's got a shower but don't want to shower, that's something that can be changed. And I think education at very different levels, it doesn't mean that you see someone, you just tell them to shower, that usually doesn't work that way. They're not going to appreciate it, and it's not going to be probably not going to yield any results. But slowly, I think and especially if people know why. If someone just tells you to go wash your hands, you say, don't tell me what to do. You need to know why. And so it's not things like, with kids hand washing and other things as well, I think, and at different levels. I think education gets built at home, at school, in the community. Like, it's not just the one source. Next, please. And then access as well. So access to health services, which is something that we all sort of are pretty familiar with, but access to other things as well that will help us to stay like that. So there's some research showing that communities that have got working swimming pools will have less cases of group A strep. And I think it's just because kids go in swim, there's chlorine in there, there's less bacteria. And so even if they're not washing their hands every 10 minutes, if they're going in for a swim once a day, that's a really good measure. If someone lives in the coast, even going for a swim, that's a really good measure. And that's other things that can do. So things like initiatives, maybe like being able to get a good access to swimming pools. I know you have to pay because everything costs, but if there's a free swimming pool, I think people will go and jump in, and that will have good health outcomes for skin. Yeah, and that's it for me. I'm going to close it there. Apologies that I ran a bit late. I got a bit carried away. But I'm gonna hand over to other David.
Thanks, David. Great presentation. My name's David Farrell. I'm based in Broken Hill. I'm project manager for the Housing for Health program. And so I'm just going to do a brief presentation on and give an overview of the Housing for Health program. It was developed by Health Habitat back in the mid-1980s in northern South Australia in the APY lands. And it was in response to people continually presenting at the local health clinic with conditions that are associated with poor housing. And so they developed what's now become to be known as the Housing for Health program. And since then, New South Wales Health has picked it up. In about 2000, they started doing projects in New South Wales. and they need to get a license from Health Habitat to run these programs. Health Habitat are very strict about the methodology and the data that's associated and being collected from these projects. And so the projects need to be run by accredited project managers and accredited team leaders. And they come out and audit these projects. So the projects, the program targets Aboriginal community-owned houses. They're houses that are owned by the local communities, usually local Aboriginal land councils or Aboriginal corporations. So it doesn't include government public housing. And the main role in Housing for Health is to assess, repair or replace health hardware so that houses are safe and the occupants have the ability to carry out healthy living practices. So that's the main focus of all the projects that we do. Just a bit of an overview of what's been happening in New South Wales. I think it was these numbers are current to the end of last year. So we've done 195 projects throughout New South Wales, which has involved 4,892 houses with 119,600 items fixed in those houses, which benefited 20,330 people. So in 2010, after it had been going for 10 years, they did an evaluation of the Housing for Health program and found that there was a 40% decrease in hospital admission for infectious diseases, but I'll touch on that a bit later. So in Western New South Wales, we're currently running 4 projects, one in Lightning Ridge, which we're sort of halfway through. Cowra is coming towards the end of it. Wellington, we just started there last week. There's 2 stages there. We're doing the first stage is the Wellington Co-op, Aboriginal Co-op, who's got 43 houses, and then we'll come back early next year and do the Land Council houses, which is 30 odd as well. And about 3 weeks ago, we started the project in Wilmaringal, and there's 20 houses there. And on the left-hand side, that's the projects that we've done in the last, since 2000, so the last 24 years. So was just been to the majority of communities that have Aboriginal housing in them, and we're just starting to go around and go back to the original communities. So with Lightning Ridge and Wellington and Wheel, we've already been there, but it was a long time ago. So we're just starting to go back now to some of the original communities. Okay. So it's all about safety and what we call critical healthy living practices. So the main safety issues that we look at are electrical, gas, fire and structural safety issues. They're the main priority. And the next lot are the first are the what we call the critical healthy living practices. So that graphic on the left hand side there shows there's 9 healthy living practices, plus the one on the top left hand corner is the safety one. But we just look at the 4 critical healthy living practices. And if we just go to the next slide, that'll show what they are and their relationship to conditions like skin infections. So the 4 critical healthy living practices are washing people, so making sure that the bathroom is functioning, washing clothes and bedding, so making sure that the laundry is functioning, removing waste safely, so all the drainage and septic tanks and all that sort of stuff associated with removing waste is working, and also improving nutrition, so making sure that the kitchen is functioning. It uses a survey fix methodology, so that photo there shows a survey team. That's actually at Nyngan that we did a couple of years ago. It's really important to have the community involved. A lot of those people may live in the houses, or their family live in the houses, or they know people who live in the houses. So because we need to get in there and survey the houses to find out what's going wrong, it's really important that we have the community involved to be able to build up a good relationship with the community and ultimately get access to the houses, because it's a pretty invasive, intrusive type survey where we're going in checking, power points and bathrooms and toilets and, sort of going into every room in the house checking stuff. So it is quite intrusive, but having the community on board is really important in being able to do that. So for, I think in Nyngan, for example, there was about 28 houses. So we had 3 teams. Each team had about 5 people in them. One person is a team leader from health who is accredited to do the team leader role. So that would take about, to do that project, to get through 28 houses, probably take about 3.5 days. And then once we go through and assess the houses and find out what the issues are, then we have a plumber and electrician that come round following us and fixing up the stuff that we find that's wrong in the houses. And that's what's called survey fix 1. Once that urgent work's done, we'll move into the capital work stage, where we get things fixed there that was too big to be done at the survey fix stage. And they're things like, replacing stoves, replacing hot water services. If there's leaking bathrooms because of waterproofing issues, then we may need to do bathroom upgrades. We might need to do some OT stuff as well around access for anyone there that may be disabled or frail aged. So all those sort of things get done during that stage, and that usually takes 6 to 12 months. And then we come back again and do the second survey fix, and that's to mop up anything that we might have got missed in the first survey, or things that might have happened in between. And it also gives us a before and after picture, so we can compare what the houses were like before any work was done and what they're like once all the work's been completed. Next slide. So when we do these surveys, once there's about 240 items that we check in each house. All that information comes back to an office that we set up, usually at the Land Council office, goes into a database, and that then prints out jobs for the plumbers and electricians who start the day after we start surveying the houses. So the plumber and electricians in the community at the same time we are doing the surveys. So that's just a picture there of someone entering the data. So we'll come back to the office, drop off the survey sheets that have been completed for that house. That gets entered into the database and then prints out jobs for the plumber and electrician. That's all. There's no information that goes into the database that shows what the any addresses or people's names or anything like that. Each house has got an ID number, so it's all de-identified. And all this information then determines how the house is functioning. So I'll just explain that a bit more on this page. So this is a sort of a graph that we can that's developed from the data that gets entered into the database. So on the left-hand side, you've got the healthy living practice indicators. I don't know if you can really read that; it's a bit small, but you've got at the top there, store prepared and cooked food, drains working, flush toilet working, laundry, washing children. That's the highest priority. The main focus of it is children 0 to 5 is the main target population for these programs. The shower working, fire safety, structure and access, gas safety, electrical safety, and making sure that it's connected to services. So on the left-hand graph, that's what the houses are like. This is an example of the houses in the period 2020 to 2022. So on the left-hand side was what the houses are like when we did the first survey, and then on the right-hand side is what the houses were like after all the work had completed. How that's worked out is, for example, for the shower, there's 7 critical items that need to be working fully for the shower to meet the minimum standard. So if only 6 out of 7 items are working, it's not considered okay. So that graph shows only the percentage of houses where all of the criteria are met for each healthy living practice indicator. So for the shower, for example, that's halfway down that list. When those houses were checked, only about half of those showers were working. So then the plumber got in, did the work that was required. Then when we come back and did the second survey after that work had been finished, then 100% of those showers were working. So it's good to be able to, we're able to demonstrate how effective, the program is when, what the houses are like before we start and what the houses are like when we finish, and we can give that information back to the Land Council or the Aboriginal housing provider as a way of showing, the effectiveness of the work that's been done. So just moving on, and yeah, so that just going back to that evaluation, there was a health outcomes evaluation done in 2010, which showed that those that received the housing for health intervention had a significantly reduced rate of hospital separations for infectious diseases, which happened to be 40% less than the rate for the rest of the rural New South Wales Aboriginal population. So it was a really good outcome, and that's probably the reason why we continue to do housing for health programs to this day. So the things that they looked at when they were doing the evaluation were the skin, respiratory, enteric, or gastro type diseases, and otitis media. So the messages that the sort of are really important to come out of this Housing for Health program is that it's shown to reduce the rates of infectious diseases, particularly those associated with skin, respiratory and gastro diseases, all of which are higher in Aboriginal communities in New South Wales. And it's really important to know that, that the repeat infections can be risk factors for chronic diseases later in life. And David mentioned, the importance of education and health promotion and those sort of things. But these programs like this, make those sort of things a lot more effective if people can go home and the bathroom's working and the shower's working and, they've got hot water and all those sort of things, because it's sort of the message starts to fail a bit if they come home and, after, getting all this hygiene education, all that sort of stuff, but they can't go, if they go home, they can't carry out these sort of healthy living practices, then, it's sort of, it breaks down a bit. That's it for me.
Wonderful. Thank you, Davids. Well, I can certainly say that was an excellent presentation from where I'm sitting, and I have learnt a lot from both Davids. I think this is a good time for people to raise their hand or pop a question in the chat. I haven't seen any pop in at the moment, but I can see in the chat that we've got some TAFE students that are listening in. So I'm wondering if that room has got lots of questions with regards to these wonderful presentations that they've listened to this morning. But I do welcome anyone to raise their hand if there's any questions. Maybe the guys have answered all the questions. Oh no, Gwen, do you want to unmute and ask your question?
Yeah, I don't know where my face is gone, but I promise I'm here. I was just really interested in the stuff that you guys have presented today. So very, very good to see that a lot of these things are still on the table to be discussed and looking at how we actually do things. I actually worked with the Australian Trachoma Alliance out of Alice Springs, and one of the programs that I was actually in charge of was developing some strategies in communities that looked at some of those. It was about trachoma at the very beginning, but it actually escalated to things like disease management and that kind of stuff. And one of those things were I actually came up with a three-pronged approach to things that could be left in the community for them to actually have ownership of when the program finished. So it was only a pilot program. One of the things that I found in observations over a week was that the schools actually had washers, so the kids could wash their faces every day, but they were picking up the washer and sharing the washers and putting it back in the tub and that kind of stuff. And like a lot of those things were shared quite categorically in the community. So a lot of those things, if somebody had, trachoma or runny eyes or something else like that, they weren't washed and they weren't sanctioned. The other one was they had a laundromat, and the laundromat actually meant that because of the dust and the sand and everything else, that it was one communal washing machine that had a laundry environment there as well. So everyone was sharing that kind of stuff. And then the other thing was the looking at how we actually got to look at how they could do that management of illness and disease into the future. So one of the programs that first part of that program was giving the kids all a travel washer that was a little thing. They were all different colours, but they got to write their name on it, draw a picture with permanent markers, and they kept them. Only they could use that because they had a high turnover of students coming through that school. So only they could use them, and they had two each, different colours and everything else. The other one was the washing machines. So I actually got some travel washing machines or camping washing machines that didn't need electricity or anything else. That was actually trialled in 5 houses. Put them in there, and it actually, two of those things was that I only used a litre of water for any bed linen, any clothes, for some of the young girls who didn't want their smalls to be hung out in public as well, so they could do them discreetly and hang them out. And the other thing was soap. So buying a bar of soap in those communities was nearly $10. So we got some soap making happening there, looking at some of the bush medicines that they had, that they used, incorporating that into something so simple, just having moulds and everything else. Are they still doing that? Those kinds of things there. So that was with the Australian Trachoma Alliance that I was actually instigated in that community. So I know a lot of those aspects are still happening now, and that was more than 5 years ago.
When that just sounds astoundingly wonderful, and what great initiatives to back up health and wellness. And I sincerely hope that those measures are still in place, as you say, because as these guys have demonstrated that access to washing machines and clean face washes and stuff like that to stop the spread of infection is really, really important. Thank you for sharing, Gwen.